Hello everybody, welcome to my presentation on the basics of mechanical ventilation. My name is Terrence Shenfield and I've been an education coordinator for over 30 years at a major trauma center, and I am also the co-owner of A&T Lectures as well as Atacam. This particular course, I started making it very basic to understand how mechanical ventilation works. My audience was basically new respiratory therapists and nurses who wanted to understand how it worked. But as I started putting this together, I realized that mechanical ventilation is really not a basic tool. It's a high-end tool, and so I went into a little bit more detail. By the end of this presentation, you're going to have a good handle on how mechanical ventilation works, and you'll be able to take care of your patients at the bedside much better than before you watch this video. So what is a mechanical ventilator? A mechanical ventilator is a device that can support ventilation in a patient who can't breathe on their own. There are many types of ventilators. You got neonatal ventilators, you got pediatric ventilators, you got adult ventilators, you got home care ventilators, you got transport ventilators. I mean, the list goes on, and everyone swears that their particular ventilator is the best. I believe that a ventilator is best operated by the user. In other words, the skill of the person who is setting up the ventilator and manipulating the ventilator is what makes the difference in patient care. Ventilators have been around for a long time. Back in the 1800s, they used to use negative pressure ventilators, iron lungs. I'm sure you all heard of it. And probably about the 1940s, they started developing positive pressure ventilation. And, you know, from that point on, they got all kinds of bells and whistles that go along with it. I don't endorse any particular ventilator. I will tell you like a broad stroke of exactly what kind of ventilators are out there, what kind of modes they have, which is more important. And more importantly is how you use the ventilator. Today's objectives are varied. Number one, I'm going to describe the role of mechanical ventilation in patient care. There are many times a patient comes out of the operating room, they had general anesthesia, and they're fully sedated and paralyzed, and they need some form of mechanical ventilation to breathe. There are types of traumas. Patients come into the emergency room with chest trauma or cardiac arrest. They need mechanical ventilation. There are other cases where someone has some kind of pulmonary disorder and they need mechanical ventilation. So I'm going to get a little bit more detail about when do we use mechanical ventilation a little bit later. I'm going to also describe the settings involved. If you have a mechanical ventilator, this is a critical piece of equipment that potentially, if it doesn't operate appropriately, the patient could die. So you really need to keep a ventilator, basically, especially with someone who's acutely ill, in the ICU setting. I'm going to talk about the different pressures involved with mechanical ventilation, and especially in regard to lung mechanics. You know, I'm going to talk about peak airway pressures, I'm going to talk about plateau pressures, I'm going to talk about PEEP, I'm going to be talking about, you know, all different types of pressures, transpulmonary pressures, everything involved with mechanical ventilation. I'm also going to describe some different modes of ventilation, some of the real basics. Like I said, this particular PowerPoint is on the basics of mechanical ventilation, so I'm not going to go into super detail about APRV or other type of ventilation strategies, but I definitely am going to cover some of the basics that you need to know. Cyst Control, volume control ventilation, pressure control ventilation, pressure support ventilation, CPAP, so on. You know, some of the real basic tools. Another important thing I'm going to be talking about is the ventilator alarms. A lot of times we become desensitized to a ventilator alarm. Sometimes you're in an ICU, you hear alarms going off all the time, and you really don't know how to differentiate between what's a critical alarm versus a different type of alarm. And then I'm going to briefly talk about weaning the patient from mechanical ventilation. I have other PowerPoints I talk about weaning strategies. So I'm going to go over some basic weaning strategies, you know, because you don't want someone to stay on a ventilator. The key point is, there's a reason why they're on mechanical ventilation. You need to intubate them. You need to maintain their airway. And then hopefully they get better. And when they get better, you want to get them off the ventilator because, being on a ventilator can potentially harm the patient. So I'm going to talk about some basic weaning strategies. So what is a mechanical ventilator? A mechanical ventilator, in many different manufacturers, different modes, different types of settings. Everyone swears that their ventilator is the best on the market. But basically, it is a tool that delivers a set tidal volume or a variable tidal volume pressure, and it's set by time, flow, and what the goal of this is to ventilate a patient who cannot ventilate themselves, or to assist ventilation for someone who cannot breathe fully. The picture on the left shows you a man who's intubated with an endotracheal tube, and that goes down the trachea. And then you notice on that particular tube, there's two limbs. There's a blue limb and a white limb, which means one is for inspiration and the other one is for exhalation when the patient exhales. The settings on a ventilator, there are many. There are different modes. There are Cyst Control, SIMV, pressure support ventilation, pressure control ventilation, APRV, APV. There's so many different modes of ventilation. And I'm going to get into some of the basic settings. But the goal of mechanical ventilation is to assist a patient with breathing who cannot breathe on their own adequately. And what you do is you set yourself up with a tidal volume, you set yourself with pressures, you set your time with an inspiratory time, you set yourself with a respiratory rate, you bleed in oxygen, which is called FiO2, and you really assist them with their ventilation. There's a big difference between positive pressure ventilation that a patient gets from a mechanical ventilator versus spontaneous breathing. They are completely different modes of operation. I would strongly suggest that any kind of patient who's on mechanical ventilation, if they could spontaneously breathe, let them do some own spontaneous breaths. You don't want to take their respiratory drive away. You really want them to sort of work. The diaphragm with spontaneous breathing, it pulls down, and that negative pressure that is forced by the diaphragm going down forces air into the lung. So that's how spontaneously breathing works. But in regard to mechanical ventilation, it's positive pressure, and it's a little bit different. There's some harms comes with positive pressure if you don't monitor how much pressure the patient's getting or how much tidal volume, and we're going to get more into that detail. So mechanical ventilators are tools used to support ventilation when a patient can't do it themselves. So why do we need to have mechanical ventilators? Why is that a very important tool to have in the ICU? There are many different conditions, so I'm going to go over a couple of different conditions where mechanical ventilation is really important. Suppose someone has some kind of pulmonary disorder like pneumonia or sarcoidosis or some other form of lung disease. And as a result, they can't get adequate oxygen into their lung. So what you can do with mechanical ventilation is if you intubate somebody, you could deliver variable FiO2s to the lung, meaning they have different concentrations of oxygen in the lung. And at the same time, you could utilize PEEP, which we're going to get a little bit more into that. Suppose someone has an exacerbation of COPD and they retain too much carbon dioxide, or suppose someone has a drug overdose and they stop breathing and they retain too much CO2 in their lungs. Mechanical ventilators can actually remove the CO2 from the lungs by increasing the minute ventilation. Sometimes patients who are ill or sick, the amount of energy they utilize to breathe, and the amount of energy it takes for them to use their diaphragm, and if they're really having some kind of respiratory disorder, they breathe real fast. That energy requirement, or someone with asthma or someone with COPD, they're really laboring to breathe, they could tire out eventually, and if they tire out too much, they're going to stop breathing because they're going to see their CO2 is going to retain. A lot of patients who come in for an emergent, who get general anesthesia, they come in for an operation, they get a hip replacement, they get a knee replacement, they get any kind of cardiac surgery. They're under general anesthesia, they're not breathing at all, they're paralyzed. So absolutely you need to have mechanical ventilation on board. There are also patients, like me personally, I work at a rehab center where there's a lot of spinal cord injury, as well as patients with neuromuscular disease. Patients with spinal cord injury or nervous system disorders like neuromuscular disease can sometimes hypoventilate. They cannot ventilate properly, so a lot of times they're put on mechanical ventilation at night, and then there are some cases where they're on it for 24/7. All depends on the severity of the illness. Other cases of using a mechanical ventilation, if someone becomes unconscious due to severe infection, building up toxins, drug overdose, cardiac arrest, any of those patients who cannot breathe for those following cases benefit from mechanical ventilation. So mechanical ventilation is life-saving. It can really make a difference for so many patients. There's some people who use mechanical ventilation for a short period of time just to get over whatever medical ailment they have. And then there are people, like I said, with neuromuscular disease who are on mechanical ventilation for life. So mechanical ventilation is a very, very important tool, and how you use it is even more important. Let's talk about tidal volume. What is tidal volume? When we breathe in normally, when we take a breath in and we take a breath out, and I'm not talking about taking a deep breath, I'm talking about just normal breathing in and out, that is called tidal volume. And our typical tidal volume, if we're not intubated and we're breathing spontaneously just the way I'm doing right now, or just the way you are listening to me, your typical tidal volume is about 5 milliliters per kilogram. So when we put someone on a mechanical ventilation, there was a time when we used to put 12 to 15 milliliters per kilogram tidal volume on people, causing all kinds of harm. When I first started being a respiratory therapist, that's what we used to do. But now the preferred tidal volume for mechanical ventilation is approximately 7 to 8 milliliters per kilogram. And another very important fact, if there's any kind of injury to the lung, supposedly pneumothorax or ARDS, we want to use a lower tidal volume strategy, 4 to 6 milliliters per kilogram. Now, tidal volume is based upon height and weight. That is how it's based. So just because someone is 5'8" and weighs 170 pounds, or someone's 5'8" and weighs 300 pounds, they would get the exact same tidal volume. You don't adjust tidal volume based on weight. Because someone is overweight doesn't mean their lungs are bigger. So tidal volume is based on height and weight. And this is a very important factor. So, we've been doing this for the last few years. We've been using what is called the ideal or the predicted body weight. And what that means is based upon your height and your weight and your sex, male or female, you will be having a set tidal volume. Now, I have the formulas below for male and I have the formulas for female, but a lot of times today there are charts and they based upon your height and your weight and your sex, and they give you a tidal volume you should be delivering. So keep in mind that if someone's in ARDS or has any kind of lung injury, you want to use a lower tidal volume strategy. And if someone is just on basic mechanical ventilation, you want to really give them a tidal volume of 7 to 8 milliliters per kilogram. And also keep in mind that you and I breathing spontaneously, very normal physiologic breathing is about 5 milliliters per kilogram. So don't give high tidal volumes based upon someone's weight. If someone's 6'2" and weighs 400 pounds, don't think that they are, deserve a bigger tidal volume than someone 6'2" and weighs, 200 pounds. So keep in mind height weight, and sex is really important, and they got formulas to determine exactly what kind of tidal volume, and it's always measured in kilograms. Somehow they always say the number of milliliters or cc's per kilogram is important. So use this number, 7 to 8 milliliters per kilogram under normal circumstances, 4 to 6 milliliters per kilogram under ARDS, and if someone's spontaneously breathing, you could figure about 5 milliliters. So thinking about that, if someone's on pressure support, you might want to dial up their pressure support that when they take a spontaneous breath, that they're getting approximately 5 milliliters. This way you could get alveolar ventilation. Let's talk about another very important parameter, respiratory rate. When you set a respiratory rate for a patient on mechanical ventilation, it could all depend on which mode of ventilation you're in, and we're going to get a little bit more into the modes later. But a typical respiratory rate is anywhere from 8 to 12 breaths per minute, and this would be a normal setting for a patient on mechanical ventilation. If a patient has intracranial injury and you want to blow off CO2, or if someone has metabolic acidosis and you really want to, blow off the CO2, you might have to increase the respiratory rate. But under normal conditions, a respiratory rate is anywhere from 8 to 12 breaths per minute. So that's where you set it. Let's talk about the obese patient. A lot of times, obese patients tend to have a higher respiratory rate setting because they have a lower tidal volume. So your questioning is, why do they have a lower tidal volume breath compared to a normal patient? And a lot of it has to do with the abdomen being pushed up, the diaphragm being shortened due to the obesity in the abdominal cavity. So sometimes patients who are obese, you might have to set up a higher respiratory rate, like 15 to 18, because they're going to have lower tidal volumes based to the fact of their diaphragm being displaced. Another very important factor, if you take respiratory rate times tidal volume, this equals minute ventilation. Normal minute ventilation for patients is anywhere from 5 to 8 liters per minute. If you see someone on mechanical ventilation breathing above 10 liters per minute or 12 liters per minute, there's something going on there, and you really got to look at that. It could be that the patient is in pain. It could be that they have some kind of metabolic disorder. So you really got to look at that. But under normal conditions, minute ventilation should be anywhere from 5 to 8 liters per minute, and your normal respiratory rate should be 8 to 12. If you happen to be obese, it could be a little bit higher. If you have any kind of requirement for hyperventilation, like I mentioned before, intracranial injury or metabolic acidosis, you may have to increase the respiratory rate. There is another setting on the ventilator called inspiratory time, or I time. When you think about I time, think of IE ratio. So for example, we normally breathe like a 1 to 2 I ratio, which means that 1 second is on inspiration and 2 seconds on exhalation. A normal setting for mechanical ventilation for an I time for an adult is anywhere from 1 to 1.5 seconds. Now, the advantage or the disadvantage of increasing the I time, if you have an inspiratory time greater than 1.5 seconds, that is a way of improving oxygenation. So I wanted to show you. You see the distance between here and here? That represents the IE ratio, the total amount of time. Now, this right here, they increased inspiration. And what happens is the longer you make your I time, the higher level of mean airway pressure. Notice that this level right here goes up right here. So as you increase inspiratory time, you increase mean airway pressure. Increasing mean airway pressure will improve oxygenation. The problem with that, it's at the cost of CO2 removal. So for example, if you have a patient who's a COPD, you may want to have a very short I time and a longer expiratory time for them to remove CO2. And you can see right here, and I got a good picture of here. So this is the flow. So the breath comes in, and then it goes, exhales, and then there's a little dilation, and then all of a sudden it takes another breath in, and the whole bit like that. So the point what I'm trying to say is a shorter I time is good for CO2 removal. A longer I time increases the mean airway pressure, improves oxygenation. You want to get the right IE ratio, and typically for a normal patient it's 1 to 1.5 seconds. I typically set it to about 1 second. And if you have a COPD, you may want to shorten the I time to 0.7, 0.8, so you have more time to exhale. And I'll show you the next picture which this makes sense. This is an example how I time or a quick respiratory rate can create what is known as auto-PEEP. And I wanted to show you the graph of this right here. So what happens is this time here to here is your I time. So the patient exhales. As they're exhaling, right? They're exhaling. They keep on going here all the way down here. And then here a new breath is delivered. I wanted to show you when that new breath is delivered below this axis line right here, and you can see the breath coming in straight up here, they are intrinsic PEEP. That is called auto-PEEP. And that could be what is known as air trapping. So for a COPD, you really want enough, you want a short I time, a long E time. You want to decrease the rate. Why? Because you want to give them time to exhale to baseline like that right there. Then a new breath will come in. You don't want to have a prolonged expiratory phase going along with that. So this is the whole concept of auto-PEEP or intrinsic PEEP, is to solve intrinsic PEEP, shorten the I time, decrease the respiratory rate, and sometimes you could increase the inspiratory flow, which I'm going to get into in the next slide. What you want to do is avoid auto-trapping, which is like right here. When a breath comes in below baseline, you could recognize this on a ventilator waveform. That is what you don't want. Another setting on the mechanical ventilation is known as inspiratory flow. And let me just give you a little background inspiratory flow. Think about when we take a deep breath in, that flow of air going into our lung is called inspiratory flow. Now, we could deliver that flow through a normal spontaneous breath, or we could do it through positive pressure ventilation. On mechanical, or say someone who's spontaneously breathing like you and I, our typical inspiratory flow is anywhere from 20 to 30 liters per minute. So spontaneously breathing patients, not patients like you and I, or even patients who are not intubated, they breathe at a flow about 20 to 30 liters. When you put a patient on mechanical ventilation and you put them on volume cycled modes, we typically set the flow to about 60 liters per minute. And why is that the case? We don't want to set the flow, inspiratory flow to the patient, because they're going to have what is a flow starvation. So a typical setting for inspiratory flow on mechanical ventilation in volume cycled modes is typically around 60 liters per minute. Now there are exceptions, and I'm going to go into these exceptions right now. There are special hybrid modes called PRVC, VC+, or autoflow. Each particular manufacturer ventilator has these particular modes. I'm not going to get into them exactly, you know who they are. So the thing with these modes is that the inspiratory flow, when you put these modes on, based upon the inspiratory needs of the patient, flow would be automatically delivered to the patient. So you don't have to set inspiratory flow on these modes. It's automatic. So the patient will always get what they want. So if they're breathing fast, they're going to get the flow they need. Also, Pressure control ventilation has the same kind of flow delivery. It's a variable flow based upon inspiratory needs. So the difference between volume cycle ventilation and pressure control ventilation is inspiratory flow with pressure control is variable based upon the needs of the patient. You don't have to set anything. Volume cycle ventilation, like a Cyst Control SIMV, you need to set an inspiratory flow to approximately 60 liters. And I'm talking about adults here. And if you happen to use these specialty modes, PRVC, VC plus, or AutoFlow, you don't have to set your inspiratory flow because, again, it's pretty close to pressure control ventilation. The inspiratory flow is based on demands. So these are your basic settings for inspiratory flow. So let's talk about PEEP. Quite honestly, I could spend the next 10 slides talking about setting PEEP. And I do have a separate presentation that talks about the exact details of setting PEEP. But for this one, because this is an introduction to mechanical ventilation, I'm going to sort of quick and dirty get over it. And I know I'm going to cause a little controversy here. Typical settings for a patient who's on mechanical ventilation is anywhere from 5 to 8 centimeters of water of PEEP for them on mechanical ventilation. As someone with sick lungs, pneumonia, ARDS, a whole host of other conditions where their lungs are not oxygenating properly, increasing the PEEP directly improves oxygenation. The problem with PEEP, it could cause cardiac compromise like cardiac venous return. It could also cause air trapping. And a lot of times when you put a lot of levels of PEEP, you have to do what is known as a PEEP maneuver or determine the intrinsic PEEP of the ventilator. A lot of ventilators have this feature, and basically it's a expiratory hold on the patient, and you could determine the intrinsic PEEP. Intrinsic PEEP is trapped gas in the lung. So the point is, you know, if you have someone high levels of PEEP or if someone who's a COPD, you really want to check their intrinsic PEEP. And once you test it and you check their intrinsic PEEP, you set their PEEP level 1 or 2 below that setting, and this will give you a way of stenting the airway. So in summary, starting numbers of 5 to 8 centimeters of pressure for mechanical ventilation with PEEP. If someone is not oxygenating well, you want to increase the PEEP to a certain point that you don't decrease venous return. And also you got to be aware of auto-PEEP, and the way to fix it is generally check your intrinsic PEEP and then set your PEEP level 1 to 2 below that level, and that sort of will figure it out. And you could do this via waveforms. Like I said, I have a whole presentation on this, and I don't want to spend the next 10 slides as an introduction to PEEP to solve this. Let's turn our attention to FiO2. And FiO2 is a fraction of the inspired oxygen. And the levels of FiO2 could be anywhere from room air, which is 21% to 100% oxygen. And you know, when you have someone on mechanical ventilation, if you have someone who's in cardiac arrest, who's really sick, you know, you may want to start them off with a higher level of FiO2. But if you have someone on mechanical ventilation who just came out of post-op, you know, they had a hip replacement, really, you could start them at a much lower level, then get a blood gas in 30 minutes or so. So the goal is you don't need to keep someone at a saturation of 100%. You know, and if someone's, you know, 75 years old, a sat of 90 is good. So basically, you should keep the FiO2 as low as you can. A typical setting on mechanical ventilation is you really want to keep the FiO2 50 to 60%, and then utilize PEEP. So if someone's not oxygenating well and you have them on mechanical ventilation, once you get up to a point of 60% FiO2, your next move is PEEP, PEEP, PEEP. It's not to increase it to 70%, 80%, and so on. So the goal of using FiO2 under normal conditions. You could get by with 30% FiO2 under normal conditions. Someone in cardiac arrest, you could give them 100%, but then you really want to wean down that FiO2. The major problem with high levels of oxygen is oxygen toxicity, and this has become quite prominent these days. Oxygen toxicity results in CNS and pulmonary disorders. It could cause bleeding of the lungs, it could cause tremors, it could cause so many things. Think about this: when you have high levels of FiO2, you're increasing the free radicals in the blood, and this causes all kinds of inflammatory stuff. So the point I'm saying to you, if someone try to keep your FiO2 less than 60% on so many cases, and if they're not oxygenating well, utilize PEEP. Most ventilators have a way of measuring what is known as compliance and resistance. And you say, why is that important? I found it very important when I used to do my education with my staff, that I wanted them to understand what resistance and compliance was. So let's talk about compliance first. Compliance is the change in volume divided by the change in pressure. So what that means, as the ventilator delivers a tidal volume, a breath, it increases in pressure. So the relationship between volume and pressure is compliance. The stiffer the lungs, so as lungs become very stiff due to different types of conditions like ARDS, the amount of pressure to deliver a set tidal volume increases. So why is this important? This is important too, so you could see if the patient is getting better or worse. When you also think about compliance, total lung compliance is a mix of both the pressures in the lung and the pressures in the chest wall, which can sometimes be deceiving. For example, total lung compliance could be very high, but that could be very high because you have someone with kyphoscoliosis, or you have someone who's morbidly obese. Their total lung compliance is going to be very high because of the chest wall, the impediment of the chest wall, but not necessarily the lung. So the only way to get a true value of lung compliance, or at least to get a good estimate, is esophageal pressure monitoring. And they put an esophageal balloon down into the stomach, and then they can measure lung volumes that way. That is the best way to do it. But from a normal point of view, if you have a patient on a ventilator, say for ARDS, I would be monitoring their compliance values, because you could see if they're getting worse or if they're getting better. I used to, when I was worked up in the ICU, I would trend compliance over a few days, and then I would look at the trend line over a few days to see if the patient is getting better or getting worse. I would also do the same thing with patients with COPD or asthma. I would, instead of measuring compliance, I measured resistance. So the point I want to try to say here is measuring compliance and resistance is really important based upon the condition of the patient. If you want to see if they're getting better over time, trending is a very important tool. And part of my education with my staff was they knew how to trend things perfectly. And when I worked up as an ICU therapist, if I had a patient who was in ARDS, I would trend their compliance over days. I knew if they were getting better or worse. So understand how to use compliance and resistance, what kind of conditions it matters to, and most ventilators have it as the picture on the lower left. They show resistance and compliance right there on the screen. As I was mentioning before on the previous slide, using an esophageal pressure balloon, it could be very, very important in measuring transpulmonary pressures. Transpulmonary pressures are the pressures in the lung only, and they do not take into effect the chest wall, which if you get total lung compliance, that matters the lung as well as the chest wall. But if you get transpulmonary pressures, that is only lung pressures. Why is it valuable? You could measure transpulmonary pressures with an esophageal balloon, and then you could reset your PEEP to the proper level. Sometimes setting PEEP based on total lung compliance is not really accurate because you're including the chest wall impedance. So what you really want to do is get an esophageal pressure monitor, and then you can measure the transpulmonary pressure. And if you measure the transpulmonary pressure, you can do a much better job of managing their PEEP on the ventilator. I just thought I'd throw that out there. Peak inspiratory pressure, PIP. Peak inspiratory pressure is a combination of both resistive parts of the airway as well as compliance. Let me give you a better example. I'm going to draw a little picture. So when someone takes a breath in, they go all the way up. The maximum pressure right here is called your PIP, or your peak inspiratory pressure. And it's a combination of two different things. It's the compliance of the lungs, which is this area here, as well as the resistance. Resistance is a combination of your airway caliper as well as the endotracheal tube or tracheostomy, whatever you got. So, and then if you took at your PEEP pressure, PIP pressure, which is right here, and you minus the resistance, you get what is known as the plateau pressure. So peak inspiratory pressure is a very good gauge to determine how much pressure it takes to inflate the lungs. And a lot of times, a normal peak inspiratory pressure is anywhere, it should be under 30. Studies have shown if your peak inspiratory pressure is greater than 40, your mortality goes up. A lot of times, patients with high peak inspiratory pressures end up going on pressure control ventilation because you could lower the pressures that are being delivered to the patient. So just keep in mind that peak inspiratory pressure is monitored. It's something to look at. It's a combination of both compliance and resistance. It's the highest pressures delivered to the lung, and it's also attributed to lung injury. So you really want to keep your peak inspiratory pressures low, and more importantly, you're going to have to look at your plateau pressures, which is the next slide. So I used the same graph to show you the forward plateau pressures. As I mentioned before, this is your peak inspiratory pressures, right? And the area between here, this area right here, is resistance, right? So if you take resistance away, what you're left with is plateau pressures. Plateau pressures are measured during the inspiratory phase, and it's equal to alveolar pressure when airflow is 0. In ARDS patients, you really want to keep the ventilator's plateau pressures less than 30. Studies have shown that if you keep the plateau pressure less than 30, that the survivability and the mortality of those patients is very good. So plateau pressures is PIP minus resistance, and that's plateau pressures. So that's another common setting on ventilators, and if you ever hear someone talking about plateau pressures, you understand the difference between plateau pressures and PIP is actually resistance. Another common pressure measured is called mean airway pressure. And mean airway pressure is the average pressure your lung is exposed to during mechanical ventilation for both inspiration and expiration. So when you think about mean airway pressure, notice that it's all this pressure under here. All this area in blue is the average pressure, which is known as your mean airway pressure. Studies have shown that increasing your I time, increasing your PIP, or increasing PEEP, all increase mean airway pressure. Mean airway pressure is closely linked to oxygenation. So if you have someone on mechanical ventilation and they're not oxygenating very well, what you could do is look at your mean airway pressure, and whatever kind of settings you could do, increasing the I time or increasing the PIP or increasing the PEEP, increases the mean airway pressure. This will improve oxygenation. So mean airway pressure is a great gauge for oxygenation. So let's talk about some basic modes of ventilation. And we're going to start first with assist control. And we're going to talk about assist control because what happens in assist control, you set a rate, you set a tidal volume, and anytime the patient triggers a breath, it's exactly the same tidal volume. So I want you to take a look at the graph on the right. Notice that we have three categories. We have volume, we have pressure, and we have flow, right? So what happens is, remember I was telling you that assist control, volume cycle ventilation, you set a peak inspiratory flow, which we'll say is 60. Typically, the flow pattern for assist control is a square waveform like this. You see those square waveforms. Another thing I want you to mention is that when you set assist control, you set a set tidal volume. So that means this bottom field is tidal volume. Every breath exactly the same tidal volume. So the point is this, you can have a respiratory rate set to 10, right? So that means 10 breaths per minute. It's going to give you exactly the same tidal volume, say for example 500 cc's, right? I wanted to also show you the pressure forms. See this little drop in pressure right there? You see this little drop in pressure? What that is the patient is inspiring and triggering the ventilator to deliver a breath. Notice that this breath right here, this breath has no trigger. So that means automatically the ventilator will give you a tidal volume and a breath based upon the rate you set. Notice one other thing about assist control, every breath is exactly the same tidal volume. The advantages of assist control is if you have someone who's pretty well sedated and they're really not doing much breathing on their own, you could guarantee a certain minute ventilation, so you could almost guarantee that you're going to have a blood gas that's going to be acceptable. In other words, you're going to have a PCO2 level and a pH level that is going to be pretty normalized. So the advantages of assist control is that you set a respiratory rate, you set a tidal volume, and every breath that comes to the patient, either spontaneous or by machine, will be exactly the same tidal volume. Also, you could tell the difference between a patient-triggered breath by a drop right there, you see the little drop right there, versus a time cycle breath, which is just with your respiratory rate. Also notice that the tidal volumes are exactly the same. So that is assist control in volume cycle ventilation. So we get a little bit more detail about assist control in volume cycled ventilation. In other words, you're setting a set tidal volume. And as I mentioned before, these little drops right here are spontaneous breaths, but every time the patient takes a spontaneous breath, it's exactly 600. Say if the tidal volume is 600, it'll be exactly 600. Then if the patient doesn't take a breath, but the patient gets a breath automatically from the ventilator, it exactly comes in again at the exact same tidal volume. So no matter what breath they take, either spontaneous or machine cycle breath, it'll be exactly the same tidal volume. This type of mode of ventilation works very well with patients who are pretty well sick and sedated and need full ventilatory support. The second type of assist control breath can come what is known as pressure control ventilation. Pressure control. What that means is instead of setting a set tidal volume, you set a set inspiratory pressure, a set peak inspiratory pressure. So what happens is the difference with that is you set a respiratory rate, you set a set inspiratory pressure. So what's common about that is that you're going to get a set pressure, a set rate of volume coming into the lung, but you cannot guarantee that the volume will be the same. In other words, the tidal volume will be variable with pressure control ventilation. The advantages of pressure control ventilation with assist control ventilation is the fact that the pressure being delivered to the lung, you could keep your peak inspiratory pressure kind of low. So it's like a lung protective strategy. So pressure control ventilation has the benefit of controlling the pressures into the lung It also has a decelerating waveform. I wanted to show you this right here. Notice that this right here is volume cycle ventilation, and notice this right here is pressure control ventilation, pressure targeted. Notice the difference in the waveform. This one is called the decelerating waveform. A decelerating waveform actually delivers a pressure lower than volume cycle ventilation. So you're going to have a lung protective strategy. You're going to protect the lung much better. But the flip side to that, based on compliance and resistance of the lung, tidal volume can vary. So with pressure control ventilation, you control the pressures to the lung, but you don't control the tidal volume. So based on compliance of the lung and resistance of the lung, the tidal volume being delivered could vary breath to breath. So that is the big difference between both. And I just wanted to show you, just for FYI, this is right here flow, right? And you see how this area right under here, that is known as air trapping. What happens is the new breath is being delivered right here without the patient fully exhaling. And we'll get a little bit more into that. But pressure control ventilation works by setting a peak inspiratory pressure. You could control the pressures to the lungs, but you cannot control the tidal volume, which could vary breath by breath based on compliance and resistance. Let's talk about mechanical ventilators that deliver special modes such as PRVC, VC plus, or auto-flow, or adaptive pressure ventilation. All of these modes of ventilation, what the difference is that you set a targeted tidal volume. It's not a set tidal volume, but you're approximating what kind of tidal volume you want. So when you sort of set up your tidal volume target, the ventilator will deliver an inspiratory pressure to target that tidal volume, but it does it through a decelerating flow waveform. And remember I was telling you earlier about the decelerating flow waveform. The decelerating flow waveform is a waveform that delivers less pressure to the lung, and it's also lung protective. So it's almost like, so again, with these modes, you do not set a flow, an inspiratory flow. What you do is you put them on PRVC, VC plus, auto-flow, or adaptive pressure ventilation, and the inspiratory flow will be delivered automatically based on compliance and resistance, and it'll target a tidal volume, but it will not exceed it. It might exceed a couple, but it's not really much. So the point is this: it's a lung protective strategy. The inspiratory flow is variable based upon the needs of the patient, and a lot of people find these particular modes of ventilation to be quite good in the ICU because it delivers lower pressures to the patient. It targets the tidal volume you want to deliver. It targets the minute ventilation you want to deliver, and it does it at a safer way of delivering pressures rather than, overly inflating the lungs. The downside to this, tidal volumes could vary breath to breath. That's the only downside. So now let's talk about SIMV. SIMV is a hybrid mode. Basically what happens is you set a respiratory rate that is kind of low, you set a tidal volume, but the patient can spontaneously breathe in between. And let me show you what I mean. These breaths right here, notice that if you have a set respiratory rate and a set tidal volume, the device will deliver tidal volumes right here. See that? Notice how they are fixed levels, fixed heights, and they come in at the same time. At the same time, the patient can spontaneously breathe in between the ventilator, and it delivers a tidal volume based on their spontaneous effort, which is right here. The advantage of this particular mode is that you could wean the patient. So you could set a mandatory rate of, say, 6, and then you could have the patient breathe in between spontaneously, and this is a good way of weaning. As soon as they start spontaneously breathing more and more and more, you could cut off your set respiratory rate and put them right on pressure support ventilation, which is a weaning mode. So SIMV is a good mode to wean a patient. It's not is used as much as it used to be in the past, but I just want you to understand that every breath could be variable. One could be a machine breath, which is always a fixed tidal volume, versus the spontaneous breath, which is variable. SIMV could work both in volume targeted ventilation as well as pressure control ventilation, so it could work on both modes. When someone is weaning from mechanical ventilation and you want them to do all spontaneous breathing, pressure support ventilation is the mode to do. When you put on someone on pressure support, basically you do not set a rate, you do not set a tidal volume, but you set a pressure support level. What pressure support does, it augments a spontaneous breath that they can get a little bit of a boost and help with their tidal volumes. The waveforms of pressure control, pressure support ventilation are as follows. So tidal volumes vary breath to breath. Respiratory rate is not set, so whatever the patient is spontaneously doing works. The more pressure support you offer the patient, the higher level, the bigger the tidal volume. So what you could do is wean the patient on pressure support ventilation by starting, say, with a pressure support of 12, and as they're breathing spontaneously and getting normal tidal volumes of, say, 5 to 7 cc's per kilogram of pressure support ventilation, then you could wean down that pressure support level from 12 to 10, from 10 to 8, and then you could just sort of extubate them from that point. So pressure support ventilation is a way of spontaneously breathing. You could change the pressure support level to lower it as you're weaning the patient, or you could increase it if they're not getting enough tidal volume. Pressure support levels, the higher the level of pressure support, the bigger the tidal volume. The lower the level, the smaller the tidal volume. And it's a great weaning mode. Ventilators can be life-saving, but they can also be bad. For example, the longer a patient is on the ventilator, the greater likelihood they might get a pulmonary infection known as a ventilator-associated pneumonia. What happens is microaspirates go around the endotracheal tube and go into the sterile lung field, causing infection. A certain percentage of patients who are on mechanical ventilation end up getting VAP. So the idea is to get them off the ventilator as quickly as you can. Also, lung damage can cause in different ways. For example, ventilator-induced lung injury occurs when tidal volumes are too big and it overdistends the airway, and the plateau pressures are greater than 30, and it causes all kinds of trauma to the airway. Ventilator-induced lung injury is a very serious thing, and it could be protected by using a low tidal volume strategy or plateau pressures less than 30. Another concern with mechanical ventilation is known as electrotrauma. Electrotrauma occurs when the alveolar is distended and causes little stress tears in it. So electrotrauma is the opening and closing of the alveolar and little tears that occur in it. As a result of those tears, there's another form of trauma in the airway called biotrauma. Biotrauma is when those little tears occur in the airway, in the alveolar space, it releases these pro-inflammatory mediators, cytokines, that cause all kind of inflammatory damage to the lung. So you really got to concern yourself about how a patient stays on mechanical ventilation, what kind of tidal volumes are being delivered, to reduce the likelihood of getting ventilator-associated pneumonia, to reduce the likelihood of electrotrauma, which could be best managed with proper PEEP levels. And you don't want to have any kind of stress tears in the alveolar space, because that could lead to biotrauma. All of these things can cause damage to the lung, and you got to be very aware about them. So let's summarize some initial settings on mechanical ventilation. You have a patient come in, you need to put them on a mechanical ventilator, and you need to know what kind of settings to put. So, for example, if the patient is pretty well coming out of the OR or anesthesia, or they're in cardiac arrest, you really want to start off with a cyst control, right? That is a good mode to start with. If you happen to have someone who's sort of semi-awake and you want to just wean them, you might want to try SIMV. Each mode is good, and I would suggest you start off with volume cycle ventilation rather than pressure control ventilation. The FiO2 depends. Like I was saying earlier in the slides, many patients could get by with 30%, 40% FiO2, but it all depends on the criteria of this patient being intubated. If they come in from cardiac arrest, you really want to give them 100%. But if they come in because they had a hip replacement and they're starting to breathe on their own, you could really go down to 30, 40%. But remember, when you start getting into 60% and above, you got to think PEEP, and you got to increase your PEEP. Tidal volumes, we talked about there. We want to use ideal body weight as a tidal volume. So basically, based on their ideal body weight, based on the calculation I showed you earlier, you want to give about 7 to 8 cc's per kilogram. That is a decent tidal volume to start with. Your respiratory rate could be anywhere from 10 to 12. And as I mentioned earlier, if you have an obese patient, you might want to bump up the rate to about 15 because they typically take smaller tidal volumes and breathe quicker. Inspiratory flow. If you're using a Cyst Control, you want to start them off at about 60 liters per minute. If you are doing any kind of flow cycle ventilation, for example, PRVC or auto flow, you really may want to consider using, you don't have to set your inspiratory flow because it's all automatic. Remember, if you're in pressure control ventilation, PRVC, auto flow, VC+, inspiratory flow is automatic. It's based on the patient's inspiratory demand, so you don't have to worry about it. But if you use straight Cyst Control with a tidal volume, you got to consider putting a peak flow, an inspiratory flow around 60 liters. PEEP, 5 to 8 is a good starting point. Everyone has for years people started PEEP on a PEEP of 5, but as the years went on, they began to realize that, not all PEEP has to start at 5. So I like to use a range of 5 to 8. A lot of hospitals start you off at 8, and a lot of places still start with 5. Sensitivity. What do I mean by sensitivity? Sensitivity is the triggering of the vent. When a patient takes a spontaneous breath, you want to set the sensitivity to a level that this is picked up by they got pressure sensitivity and they got flow sensitivity. So depending on your type of ventilator and the type of settings you're going to put in, I would put in adequate sensitivity. It could be 2 liters per minute if it's a flow generated, and if it's a pressure, it could be -2 centimeters of pressure for sensitivity to trigger the ventilator. So these are your basic settings that you would start a patient off. And also at the same time, which I'm going to get into, you want to set up alarms on this patient, because you can't just set them up on a ventilator and not have alarms. You got to make sure that everything is working perfectly. So these are some of your basic settings. So let's talk about some very common ventilator alarms and why they're important. For example, let's start off with high pressure. What do I mean by high pressure? I'm talking about peak inspiratory flow, high peak pressure. High peak pressure will alert the clinician that the patient is having too high a pressures for the airway. Remember, I was telling you that peak airway pressure is a combination of compliance and resistance. And the higher the pressure, the more likelihood that you could cause some kind of damage to the lung. So a high pressure alarm should be typically, you could set that based on manufacturer's prescribed numbers. I've seen all kinds of different levels set to high pressure, and I don't want to get into a big conversation what it should be and what it shouldn't be. But whatever the recommendation of the manufacturer is, I would set that. Typically, it could be anywhere from 10 to 15 above the peak airway pressure. Low pressure. Why would you be concerned about low pressure? Low pressure could be the fact that the ventilator tubing has a leak. Somewhere there's a leak in the system. It could be a leak in the cuff. It could be a leak somewhere in the airway. So in other words, you want to set a low pressure alarm in case the presence of a leak with the patient. And you got to just troubleshoot where that leak occurs. Low expired volume. Basically what I'm talking about is low expired tidal volume. Sometimes patients, if you have them on pressure support ventilation and they're taking these very shallow breaths, their low tidal volume could be inadequate for alveolar ventilation. So you really want to set your low expired tidal volume alarm to a point that you're picking up enough ventilation to promote alveolar ventilation. High frequency. High frequency is a high respiratory rate alarm. Basically, if you have someone on pressure support and they are breathing above 35 breaths per minute, that's inadequate. That means that they are not quite ready to be on spontaneous breathing at this point. If they're breathing at 35, above, anything above 25, 30, that's a warning sign that they're not doing very well. So the reason you set your high frequency alarm is to determine if the patient's working too hard at breathing, they're breathing too fast, and you got to really set it up right. Apnea. All ventilation have an apnea alarm. If you put someone on pressure control ventilation or pressure support ventilation and they stop breathing, you want to know. Most ventilators set at about 20 to 30 seconds. If they go apneic, the ventilator will automatically go into a backup rate and ventilate the patient properly. High PEEP alarm. I've seen this alarm, high PEEP, low PEEP alarm, and basically I think this more or less determines whether you have a high pressure alarm or a low pressure alarm. Low PEEP typically is significant of a leak in the system. High PEEP alarm could be due to intrinsic PEEP, which I talked a little bit about before. Some people have intrinsic PEEP, they have air trapping, and this is a great alarm to do. So when you set a patient up on mechanical ventilation, you cannot forget to set up the ventilator alarms because they're very important, and don't ignore these alarms because it could be life-saving. So I have a slide here talking about weaning from mechanical ventilation. Now you could do a whole PowerPoint. I could do another 30 slides on weaning patients, different methods of weaning. Different types of patients are difficult to wean. Like for example, COPDers are very difficult to wean. Neuromuscular patients are very difficult to wean. A straight cardiac bypass, very simple. Someone with ARDS, very difficult to wean. So this is a one slide picture of what to do from a mechanical ventilation point of view, weaning them from it. First of all, you have to ask yourself, why were they intubated in the first place? If the underlying condition that required them to be intubated is resolved, for example, suppose they had pneumonia, suppose they had ARDS, suppose they had surgery, whatever the case is, if they were intubated to protect the airway and maintain it for a certain period of time, did they recover from that illness? Did they get better? Are they ready to come off the ventilator? Basically, they have to be completely resolved of any kind of condition. Second thing you might want to look at is if they're awake and conscious. A lot of times people will tell you to pick your head up off the pillow. They could also say give you a thumbs up. There have been studies showing that patients with neuromuscular disease and certain patients with head injury do not really respond. So the point is do we keep them intubated forever? So, but on the most part, if they are awake and conscious and they can put their thumbs up and they can lift their heads, this is a good sign. Also, some patients can't protect their airway. You got to be able to cough. You got to have a gag reflex. You got to be able to mobilize secretions. You got to be able to take a deep enough breath that you could mobilize secretions, because people fail in extubation attempts because of secretions. Some studies show that you need to have a Glasgow Coma scale greater than 8 to extubate, and this may not happen in patients with head injury, but most patients have a Glasgow Coma scale greater than 8, and you could extubate them. How about a respiratory drive intact? Some people need to be able to spontaneously breathe. If someone's sedated or if someone has some analgesics on board and their respiratory drive is not good, they're going to fail. So you really need to do it. There's another thing called the rapid shallow breathing index, and basically if you have a score less than 105, that's an indicator that you are good to come off the ventilator. A lot of success has been shown with an RSBI of less than 105. And finally, we get to a cuff leak. When someone has an endotracheal tube in their airway, there's a lot of time to get inflammation of the trachea. And if they have so much inflammation that there's no cuff leak, a lot of these patients who you pull the ET tube out and then their airway closes up. So one of the basic things you could do for weaning these patients is to actually deflate the cuff and see if you hear an audible cuff leak around the cuff. These are some of the basic weaning strategies, and like I said, I could do a whole PowerPoint on weaning the patient, but these overall are some of the basic tools you need to look at. In summary, there's a few things you need to know. You should know about the terminology that goes along with mechanical ventilation, like plateau pressures, compliance, PEEP, and these things. You should know how pressures and volume can cause injury to the lung. Remember, I was telling you to use a lung protective strategy. I want you to understand some of the basic settings that we went over: Cyst Control, SIMV, pressure control ventilation, and pressure support ventilation. Very importantly, know your alarms, because understanding alarms is really important. And understand how to wean a patient from mechanical ventilation. Now, I know I blazed right across that, but weaning is really important. If you're going to intubate someone, know how to get them off the ventilator as effectively as you can. A lot of times patients who are weaned from mechanical ventilation are put on BiPAP. In other words, they have some kind of non-invasive support on extubation, which is a valuable tool. I want to thank you all for joining my presentation. Here are some good references if you want to do a little bit more research on the topic. I know I blazed over this and we could go into a lot more detail, but this was a basic introduction to mechanical ventilation, and I want to thank you all for joining me. And if you have any questions, you could put it in the Q&A.